Good afternoon, all the faculty members and delegates joined here. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's Mixed Bag webinar, organized by Dr. Ritu Santwani ma'am. So it's my privilege to introduce Dr. Ritu ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is the consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. And also, ma'am is the infertility specialist, is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am.
Yeah, thank you. Thank you, Sahiti. Sahiti, just wait. I will welcome both. So, a warm welcome to all of our dear delegates who have joined all across the geography. A warm welcome to our dear faculties, my dear friend Sweta and most respected Kuldeep sir. Really thankful to you in this effort of sharing the knowledge, because this program is started with the only motto that knowledge always increases by the sharing. More we share, more we gain also. So today we are here with the two very diverse topics, as lot of requests are coming regarding related to laser. So what's the role in the cosmetic gynecology and how to treat stress urinary incontinence? Because my program is always based on whatever the request I will get from everybody, that on which topic they want to listen. So I choose the stalwarts and invite them. So by the grace of God, the all stalwarts are usually ready to come and share their knowledge. Other very important topic, all of us is still having a lot of confusions while doing the twin sonography. So who is more better than Kuldeep sir? And Kuldeep sir, I'm really thankful to you. Say no to me. I have done 5 academic marathons. Sir is always the part of my all academic marathon. And thankful to you also, dear Shweta, in spite of your busy schedule, taking out the time. Over to you, Sahiti.
Thank you.
Sahiti,
Thank
please
you.
Sahiti, please introduce Dr. Sweta first.
Okay, ma'am. I'm very glad to invite Dr. Sweta ma'am, who has done MBBS, MS, FAMS, and Masters in Reproductive Endocrinology and Infertility in Australia, Diploma in Aesthetic and Cosmetic Gynecology, Director of Fertility and Gynecology, Southern Gen Hospitals. Ma'am has been invited faculty at numerous national and international fertility conferences and also faculty at hands-on hysteroscopy and cosmetic gynecology workshop across various states in India, author to publications in indexed journals, recipient of numerous awards for her social activities. I welcome you, ma'am.
A very warm welcome,
Thank
dear
you. Thank you
Shweta.
so much, Heidi.
And one, please again show the CV, her, because she is doing very good work via this. Please again show her CV. Because she is doing very good work. She is a trustee of Nanne Kadam Foundation for helping the underprivileged children financially towards the medical treatment. That's really great. Kudos to you. Now, please
Thank
introduce
you. Thank
Kuldeep
you.
sir also. Yeah. Now, please introduce Kuldeep sir also.
Okay. Okay, ma'am. It's my privilege to introduce Dr. Kuldeep Singh, sir. Sir is from India and he practices ultrasound in New Delhi and also known for his skills in ultrasound, OBGYN, and infertility. Sir has given more than 600 talks in national and international platforms, and also Sir has been invited in many countries, including Japan, France, Spain, Italy, Dubai, Seoul, Dhaka. And Sir has received 4 awards and 3 gold medals in the field of ultrasound. He has authored 16 books on ultrasound in obstetrics and gynecology and infertility. Sir
Yeah.
has been
Her book
awarded
is,
the
yeah.
Imaging Science Award in AICOG in Delhi and also successfully running Sono School, which organizes various training programs in ultrasound in obstetrics and gynecology and infertility.
Yeah. A very, very warm welcome to you, Kuldeep sir. Sir, actually, I posted this flyer yesterday only to all my on WhatsApp group. So I got a huge response, Dr. Shweta and Dr. Kuldeep. I got a huge response from the doctors of Somalia and from the doctors of Bangladesh. Now, in the YouTube, one comment also I received, Madam, you have chosen this time the marvelous topics. Please keep on doing the good works. So, really thankful to both of you. Now, without wasting time, handing over the dais to Dr. Sweta for
Thank
her
you.
talk.
Thank you. Thank you so much, Dr. Ritu, for inviting me This is a current topic where everybody wants to know about laser is being, laser for vaginal rejuvenation is very upcoming topic. So I will not wasting much time. Can I share my screen?
Yes, 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 yes.
Can you make me co-host?
Sahiti, please make the madam co-host.
Yes, ma'am, you are
Welcome.
already.
Then I can share my presentation.
Yeah, Renu Bhatia madam has joined from Kanpur. Geeta Khanna madam has joined from Lucknow. A very warm welcome to all of you. Yes, yes. Sweta, I think she has made you co-host.
Yeah. Okay.
Yeah, we started the screen sharing, Dr. Sweta.
Can we see?
We're just able to see
Yes.
your desktop and the
Yeah.
screen coming up. I think so. Might be because of a little.
Like
Your voice is also breaking, Dr. Sweta.
Okay.
Yes, first
Able
slide
to
is
see
visible. Yes,
the
yes. we are
laser
able-
therapy for vaginal rejuvenation.
No, no, it's
No,
your slide. It's your slide coming.
Yeah, my slide is seen.
Yeah, your slide is visible. Your introduction is visible in that.
Okay. Yeah, the first one.
Yes, yes, it's visible now. Only you have to make it full screen. Yeah.
Okay. Full screen.
Perfect.
Yes, perfect.
Okay. So what is laser? The first slide is seen, isn't it?
Yes, yes, visible,
Okay.
visible.
So we'll start the presentation, not wasting much time now. So actually laser, my talk will be like, I will be introducing what is actually laser, why we need how your laser can be useful. A little bit about the mechanics of laser, if we understand, will help us in choosing the right laser, because there are lots of machines available in the market. When we understand a little bit the mechanics of it, it will help in choosing the right machine. And then its application in vaginal rejuvenation and stress incontinence. So laser actually stands for light amplification by stimulated emission of radiation. So normally in the vaginal aesthetics, when we use for the vaginal aesthetics, the optical material what we use is the CO2, the diode, or the ND-YAG laser. And laser is created when the electrons which are there around the atom, they absorb the energy from the electrical current. And because of this flowing energy, when these electrons absorb the energy, they move from lower energy orbits to higher energy orbits. And when they come back to the normal orbit, they release the photons. And these photons, they are absorbed by the mitochondrial chromophore, the cytochrome C oxidase, and initiate a chain of reactions which help in the effect or the impact which the laser brings about in the tissues. So the flow, the laser actually goes behind the type of medium which is there. So CO2, if it is the medium, it's a CO2 laser. If it's diode as a medium, it's a diode laser. And when you use ND-YAG as a medium, it's an ND-YAG laser. So these are the three different lasers which we are commonly using in the vaginal aesthetic procedures. So when it comes to laser tissue interaction, so whenever we are using the laser, when the electron is coming back, it's releasing the photons, which is actually bringing about the changes in the tissue. So when the laser tissue when there is an interaction between the laser and the tissue, the amount of impact the laser brings about on the tissue depends upon three factors. One is the wattage, what we are using the laser, the duration of time the body is exposed, and the spot size. So when the wattage is higher, the impact is more. The duration is longer, the impact is more. And if the spot size, if it's a smaller size, the depth of penetration is low. If there is a large spot size, the depth of penetration is more. So depending upon the tissue or the organ which we are targeting, we select the wattage the wattage on the laser machine which we are using, and the duration of time which we are going to shoot the laser, we are going to select according to that, and the spot size. So this is going to decide the amount of energy which is delivered to the tissue, the amount of destruction or the damage to the tissue which we are going to create is depending on all of these three factors. And the next important thing what we need to understand when we choose our laser is the wavelength. The wavelength is very important in the optical sphere. So what we are looking at is most often we don't want our laser to be ablative. So that lasers which are there are two types, non-ablative and the ablative effect. We want to use, when we are using, the vaginal tissues are gentle, they are delicate. We don't want to go for an ablative laser. We want to choose a non-ablative laser. So when we are trying to choose a non-ablative laser, it is more often it's a diode laser or the erbium YAG laser. The lasers which are less absorbed by the water are the ones which are going to be less destructive and less ablative. And when we look at the fractional CO2 laser, the wavelength is very high. It's about 10,000. So when we look at the vaginal tissue, we don't want to go for the fractional CO2 laser. Initially, when we started using the laser, most of us were using fractional CO2, which is got a high water absorption. What it does is it causes damage to the superficial tissues of the vagina. That's when it leads to vaginal ulcers or any kind of superficial vaginal injury. But when we go for lasers like diode or erbium YAG laser, they are near infrared or shorter wavelength lasers. So these are like diode laser, it's 1470 nanometers. Erbium YAG, it is 2940 nanometers, whereas fractional CO2 is 10,000 nanometers. So these are less water absorbent laser and they are going to be more effective in the vaginal tissue, causing least superficial destruction. So lasers which are going to emit the wavelengths, which are going to be poorly absorbed by the water, are going to be the non-ablative ones. The electromagnetic energy is minimally absorbed by water. It's going to give a kind of a semi-thermal or non-thermal effect. The patient is going to be comfortable. You will not have to use anesthesia and less destruction. So this mechanism of action of a non-destructive process is called as photobiomodulation. So these lasers which we are using nowadays, they are working on the principle of photobiomodulation. So photobiomodulation, it's a non-thermal and non-ablative modality. Again, it depends on the watt what we are using. If you're going to go for higher watts, non-invasive, the lasers which are of lower energy also, lower wavelength, are also going to become ablative. So the wattage what we are using is again important. So lasers like the CO2 lasers, which are going to be of higher wavelength, they're going to be absorbed by water and they're going to be typically ablative. And the mechanism of action is going to be by destruction of the tissue. Then the tissue is then going to heal with scarring. And that's what we don't want in our vaginal tissue. And so once we understand the laser, the wattage, the wavelength and all, the second thing what we need to understand is about the chromophores. The chromophores molecules which are there in every given tissue, which are going to absorb the wavelengths of the light. So whenever we are going to shoot the laser, it is going to be absorbed by the chromophores which are present in the tissue on which we are shooting this laser. So to deliver this electromagnetic energy to any given organ, like, laser has got so much application in hair, we are doing laser hair removal. Laser is being used for acne, for scars, for different tissues. So for different tissues, we need to use different wavelength of laser, different wattage, different spot size. And each of these tissues, they have different chromophores. Chromophores are they are the molecules which are present in the tissues which are going to absorb this wavelength or the energy. So the organ, which is the type of chromophore which is present in any particular organ on which we are acting, that is going to absorb the wavelength of energy, and that is going to bring about the therapeutic effect of the laser. So the different chromophores are hemoglobin, melanin, and water. These are the common chromophores. So when we talk about laser for the the vascular treatments, in which the hemoglobin is a chromophore. When we talk about skin treatments or laser hair removal, the melanin content is high in the skin or in the hair treatment. So that's why the chromophore. And in certain tissues, water content, when it is high, water becomes the chromophore. And if our intervening tissue is going to have more of this chromophore, most of the energy is going to be absorbed there, and you may not be able to deliver the therapeutic dose to the target tissue. So when we talk about our vaginal mucosa, so the near infrared or shorter wavelength, the diode laser or the erbium YAG laser, they are poorly absorbed by water, and they've got the ability to penetrate into the deeper tissues. So we want to go subepithelial when we target the vaginal mucosa and all. We want to go below the vaginal surface, and they are going to reach the target tissue without damaging the intervening tissue. So the superficial vaginal mucosa, we are not going to get the ulcerations or any kind of injury. And although the non-infrared energy is absorbed by the chromophores like melanin and hemoglobin, but in the vaginal mucosa, the melanin is absent, and hemoglobin is also present in very minute amounts. So these two are absent, so the near infrared can reach the subepithelial tissues better. That is why when we are using the laser, we keep the vagina dry. We don't use saline or anything. We just use a swab to clean the vagina so that there is least possible water content. So the superficial absorption of the tissue is not much. A superficial absorption of the energy is not much, and the energy is able to reach deeper into the target tissue where we want the action. So now talking about all the energy-based devices, whether it's laser or RF, they all work by the principle of thermal rejuvenation. So laser or RF, they act by heating the connective tissue of the vaginal wall and taking the temperatures are up to 40 to 42 degrees. So when they get to the temperature, they cause collagen contraction. There is generation, neocollagenesis. There is neocollagenogenesis. There is regeneration, restoration of the neocollagenogenesis happens, neovascularization happens, new blood vessels, collagen remodeling, and the restoration of the elasticity and the moisture of the vaginal mucosa. There's another proposed mechanism is by activation of the heat shock proteins. So the energy-based devices, because of the heat or microablations which they cause, there is activation of heat shock proteins, and this increases the level of the different growth factors, the transforming growth factor, the interleukins, and all are increased. The metalloproteins, the procollagens, all of this is increased, and this inflammatory response is going to stimulate the generation of new collagen tissue. Newer blood vessels are going to improve. There's an improved microvasculature, enhanced tissue oxygenation, more of the cellular matrix formation, more elasticity of the tissue, and the epithelial remodeling happens. And the new tissue which is formed is fresh and more healthy. So the basic mechanism is the tissue remodeling with newer collagen, newer blood vessels, and improved vaginal mucosa. So now coming to the application. So after understanding, the basic principles of laser, the energy-based devices, what are available in the market in the laser, RF, and the different modalities of laser, if we understand the basics, it will help us in choosing the right modality of treatment for our patient, because a large number of lasers which are available, the ones which we use for the skin or for the laser hair removal, they may not have application to our vaginal tissues because they are more delicate and more gentle, and they need the lower wattage or different devices are there for the vaginal use. We cannot apply the skin ones to the vaginal area. So we need to use the right treatment. And then now coming to the different indications. So in area, for the vaginal aesthetics and vaginal regenerative gynecology, the various applications are in vaginal rejuvenation and vaginal tightening, in stress urinary incontinence, mild to moderate stress incontinence. We see a lot of patients with vaginal atrophy, because of age-related issues or otherwise, and recurrent vaginal infection. We see a lot of patients with repeated vaginal infections. We've been repeatedly treating them with antimicrobials, antifungals, still they are not responding. One sitting of laser helps in remodeling and newer healthy and more moisture to the tissues and help in better control of this recurrent vaginal infection. In GSM, GSM is a new term coined in 2013 by the North American Society for the genitourinary syndrome of menopause. So the different changes which happens because of the aging of the vaginal tissue, they have termed it under the heading of genitourinary syndrome of menopause. Patients coming with vaginal dryness and vaginal itching, in all of these patients, there is an indication to use laser. So what happens is following childbirth, there is loss of collagen and elastin in the vaginal tissues, and the women experience muscles and tissues leading to laxity. So where we can offer this vaginal tightening. Often because of loose vagina, the patient feels sexual dissatisfaction, loss of intimacy is there, and during the sexual intercourse. So that is also one of the common indications. Today's women is different. They are very open about their sexual health and what they desire. So we have to respect that. And when any woman is approaching us, so we don't have to be judgmental about it. Whenever there is vaginal looseness or sexual dissatisfaction, it is a right of the women for asking for such treatments. And of course, medical indications where there is a pelvic organ prolapse, type 1, degree 1 prolapse or mild to moderate incontinence because of the vaginal looseness. There is leakage of urine, and then the patient can come forward for this. We see young women. Even, I recently treated a 27-year-old who has come with me for secondary infertility. So she has looseness of vagina, and because of which she's leaking urine, stress incontinence on coughing or sexual activity, there is leakage of urine. And when we offered her just after one sitting of vaginal tightening and for stress incontinence and vaginal looseness, we did one sitting of laser, and she conceived in the second month, that improved her sexual life. And that was the only treatment for her secondary infertility. So definitely, even younger women we are seeing with the urinary incontinence. Of course, there is a large load in pre and post menopausal age group where there is an indication for stress incontinence. So we know stress incontinence where there is an involuntary loss of urine on exertion, sneezing, coughing. And in grade 3, even with no such activity, also there is leaking. And a lot of middle-aged women, about 4 to 35% of women in middle age are shown to have this problem. So the burden of stress on continence in the society is much, much more than what we know, or much less than what the number of women come to our clinic for treatment. A lot of women are silently suffering and living with this problem. And they hear from their mothers or grandmothers, this is a normal part and parcel of aging. And we have lived with this, and they think that, but they're not aware of the treatments what are available, and they are not at all approaching us. And the kind of treatments what we recommend, pelvic floor Kegels exercises and all, they're not enough to control this stress incontinence problem. And quite often, as we know as doctors, we treat them, we teach them to go for this pelvic floor Kegels exercises, but they are not compliant with that. They do it for a couple of months and then they drop out from this. So the pelvic floor dysfunction, what we see due to altered metabolism of the connective tissue, there is lots of sufficient support for the urogenital tract, and that's what is leading to this problem. And when we talk about the genitourinary syndrome, it's about 15% of the premenopausal and 40 to 54% of postmenopausal women are suffering from this. So genitourinary syndrome, it includes all the vaginal dryness, vaginal itching, looseness of vagina, the incontinence, all of that which a woman faces after the menopause because of the drop in the estrogen levels and lack of the estrogen support to the genitourinary area. And it's a very important problem which we need to address because of the increasing life expectancy. There are a lot of women in the postmenopausal age group who are suffering silently with this problem. So this is not like a medical emergency, but the quality of life of the woman is affected. If you imagine, a woman with leaking of urine or disturbed sexual life because of all of this, the quality of life is affected. And everybody today, wants to look at a good quality of life, be it post-menopause, they want to have a healthy and a normal life. So the need of these treatments is immense. The demand of this treatment is huge. It is just that the patient needs to be aware of the availability and the safety of this treatment. Coming to the treatment per se, when we talk about laser, they are very simple treatments. There is no need. The beauty of the treatment is can be done on an OPD setting. You don't need any form of general anesthesia. Some patients who are very sensitive, what I do is we apply the local anesthetic, Emla cream, leave it for 15-20 minutes and then go for the laser treatment. Otherwise, most of the women tolerate without any anesthesia. So when we apply it, the patient may have just a sensation of warmth. So we put the laser, it comes with a glass tube, which we put it inside the vagina. And then we do the set, depending upon the machine which you're using, you set up the number of watts and the degree and the amount of duration. It's normally 4 to 5 minutes, the entire treatment process. So once you put the glass tube inside the vagina, we keep withdrawing. There is a 360-degree delivery of the laser energy, and we keep withdrawing it so that we give treatment to the entire length of the vagina. So it takes about 5 to 10 minutes of treatment. The patient tolerates the procedure very well. It is done only on the OPD sitting, and the patient can go back home the same day and resume normal physical activity. We advise them to avoid intercourse for 2 to 3 days, and then they can resume even normal sexual activity. Depending upon the intensity of the problem, we call back the patient 2 to 3 weeks later. Most often 2 or 3 sittings is enough for complete, resolving of the problem the patient has, whether it's vaginal looseness or stress incontinence. 2 to 3 sittings, 3 to 4 weeks apart is what most of the patients need. And if needed, they can come back once in a year for a top-up, one yearly or once in, 12 to 18 months for a top-up treatment, they can come back. If the problem is more severe, sometimes we recommend PRP along with the laser for the treatment. PRP, as we know, we take the patient's own blood and prepare the platelet-rich plasma. If it's just for the vaginal looseness, we give it all across the vagina. And if it is particularly for stress incontinence, we give in the suburethral, like when we put the sling in the suburethral region, we just give more PRP in the suburethral area, and we focus more for the laser in the anterior vaginal wall when we are doing it for the stress incontinence. So this way, it's a very simple and very safe treatment. Just after the procedure, sometimes some patients may have increased vaginal discharge. That's all we expect. So these are some pictures, depicting the impact of the therapy. When you see this before the treatment, the entire length of the vagina is so wide. In this, there is more tightening. So it is it's before the treatment and after laser vaginal treatment. So for incontinence, we focus more on the anterior vaginal wall. This is a consensus statement given by the American Urogynecology Society in May of 2020 on the energy-based devices. So focusing mostly on the genitourinary syndrome of menopause, they said that patients who are experiencing vaginal atrophy or any kind of dyspareunia because of the medical menopause, energy-based devices has shown a short-term efficacy. So even and the effect lasting for up to 1 year when they use CO2 or the erbium YAG laser. So it's got a beneficial impact on the sexual function on short term. Short term would be 12 to 18 months, but long term we don't know. So that's why we call the patient back once in 1 to 2 years for a second for a top-up sittings. most of the time the adverse side effect what they note is just increased vaginal discharge for a few days or vaginal spotting immediately after the treatment and mild discomfort at the time of the treatment, but otherwise there were not any long term side effects were not there. So there are no serious adverse effects with this treatment. So when we use treatment for the menopausal dyspareunia or atrophy, so energy-based devices have a favorable safety profile. So this is a consensus statement in 2020 by the American Urogyne Society. So just I'll share with you, a few papers where laser therapy was used as a treatment modality in a genitourinary syndrome of menopause. They looked about 200, this included four, this is an article from 2017, where they included 4 studies. They had 220 women. The collated data showed that laser therapy was valuable as a non-harmonic therapeutic modality in GSM. Most often what we give to our patient is local estrogen therapy when they come with this atrophy and all. And patients improve, but they come back to us repeatedly. So giving a few sittings, 1 to 2 sitting of laser, which is going to be very effective. So high quality evidence from randomized controlled trial is required to establish the efficacy of laser treatment in management of GSM. So we've got more of smaller studies because these treatments have been there only for a short time now, but we need more randomized trials, to further be more confident of using. So then this is another paper from 2017, which talks about its laser has gained interest in a non-hormonal treatment for GSM, and it's a non-invasive good option for stress incontinence, because most often with stress incontinence, what we can advise the women is pelvic floor exercises. If that doesn't work, we have to go for any kind of sling operations, or a vaginal tape. Not many women want to go under under a knife for the procedures. And even the tape, vaginal tape also has its own side effects. So more women are preferring to go for this lesser invasive non-ablative laser options. And when they did studies, when they used this microablative and non-ablative lasers, and they took vaginal biopsies and looked at the vaginal maturation index, and they found there were significant morphological changes in the vaginal tissues. And this can alleviate the vaginal dryness and dyspareunia. So it has reported to improve the stress incontinence, and it can be offered as a safe as first-line treatment in mild to moderate SUI prior to any surgical procedures. Then this is another paper from March 21, where they looked at 16 published clinical research studies involving 899 patients with SUI, and they found that vaginal laser is a safe, effective, and minimally invasive treatment for SUI, and it is well tolerated. So there, with time, we will have more and more papers, more and more evidence which will be coming through. As of now, laser is quite effective, and it's quite simple and a very safe modality which we can offer our patient for vaginal rejuvenation and stress incontinence. So with this, we come to our end of a talk. So just a little bit understanding of the laser mechanics will help us in choosing the right machine, because there are a lot available in the market. A little bit of knowledge is very important. And laser has a significant role in improving the symptoms of vaginal looseness, GSM, and vaginal dryness. It's good to go for a non-ablative one. It's better. It is safe, effective, and well tolerated, and it can be done in an outpatient setting. Of course, we need more studies, more randomized controlled trials to be more confident of what we are offering. So definitely laser has a big cosmetic role to play, where younger generation, younger population, adolescent girls are coming for alteration of the external and internal genitalia. That's a totally different topic, but definitely there is a medical application to it to improve the quality of life, particularly in our pre and postmenopausal women. There is a significant, I had a 70-year-old woman with a grade 1 cystocele and rectocele and vaginal looseness. At that age, nobody wants to go through a surgery. She has been through with me for 2 to 3 sittings of vaginal laser that has improved her quality of life. See, that's what she wants at an age of 70, a bit better quality of life where she's not feeling wet all the time. If she is going to feel wet all the time, it's going to cause vaginal excoriation, vaginal itching, and whatever time span she has, she wants to have a better life. So that's where, there's definitely medical indication apart from the cosmetic role which laser may have. There is definitely a medical indication, I feel, with the laser. So with this, I come to the end of my talk, Ritu. Any questions, anything, I'm
Yeah.
happy to take.
Yeah. Thank you. Thank you so much, Dr. Sweta. Such a comprehensive presentation. Will you please stop sharing the screen?
Okay.
Yeah. So I have received a bombardment of questions on the YouTube. I will take few.
Sure.
The first question is from Dr. Swati. She has joined from Kakinada. She is writing, Madam, comprehensive presentation, but which laser is good for the beginners?
See, the most often I think diode is the one which is non-ablative and erbium YAG. But again, erbium YAG, I think there is a big cost factor. So most of us are going for a diode laser because it is more cost effective. When you start as a beginner, I would recommend to go for simple diode laser to start with, and then you can keep on adding everything to your clinic, because pay some situation you may like to use erbium YAG laser. So one of these two is a better one to start with.
Yeah. Another question, yes, which laser and what's the initial cost? Diode, as you already
So
told,
this is,
she wants.
yeah, costings again, it depends on which company you go with, and also it's not that bad to start with. This probably I would think in long term, every gynecologist may be having a laser in their OPD. It's like an ultrasound probably.
Another question is from Dr. Khade. He has joined from Jalandhar.
Yeah.
His question actually somehow not very clear. He has written, Madam, prior using the laser, you make the vagina dry.
Yeah, because we see, as I said, now we just clean it with a swab. That's all. What I meant is vaginal dry is when sometimes when you like to clean the vagina, you don't want to leave water in there. Clean it with a dry swab so that the laser reaches the target tissue, so that it's not absorbed by the water. That's what I meant.
Thank you. Another question is from Dr. Jadhav. He has joined all the way from Osmanabad. His question, Madam, you have shown in one slide laser for the treatment of the recurrent vaginal infections. So, according to your experience, is this works or we have to go for the cautery and other procedures?
See, vaginal infection, what happens is when the patient has repeatedly, despite of treating with oral antifungals or even with the, like fluconazole, sometimes we treat with itraconazole and all, still after repeated treatments, if the patient is not improving with her, she's got repeated vaginal itching and vaginal infection, if we give one single sitting of laser, it's going to cause neovascularization, new collagen, and new healthy moist tissue is going to develop. That itself sometimes take care of the, it helps in the healing process. So just we don't have to do 2 to 3 sittings or a long-term treatment. It's just one of single sitting may be useful in recurrent vaginal infection is what I have experienced. And a few patients whom I have done that, they are happy and they felt really nice after that one sitting. When you're treating for vaginal looseness or SUI, you may need more sittings, but with infection, it is just a single sitting is more than enough.
Shweta, another question we are having is related to this is from Dr. Usmana Rehman. Dr. Usmana Rehman has joined from Dhaka. How many sittings you are advising for the vaginal infection?
Vaginal infection, one sitting is more than enough. I think that my last answer had answered this question as well. That with infection, one sitting is more than enough.
Okay. Another question is from Dr. Deepa. She has joined from Lucknow. Her question, ma'am, what's your experience related to Amsela chair for incontinence?
Yeah, see, Amsela chair, again, it's like when we ask, we can combine it with the laser. Amsela chair as such per se may not be the only answer to the problem of stress incontinence. We know pelvic floor exercises, when we advise to our patient, they are not compliant with the exercises. So if you combine your laser with the MCLR chair, when the patient does a 30-minute session, it's in that electromagnetic energy, which is going to cause the contraction of the pelvic floor muscles. So it's going to strengthen and tighten the muscle. So MCLR chair is going to work like pelvic floor exercises, which the patient may not do. And a 30-minute session is equivalent to doing about 10 to 11,000 times exercise. So we normally recommend patient to come for 5 to 6 sittings of the MCLR chair along with the laser treatment, which can be once or twice a week, depending upon the severity of the problem which the patient has. So definitely we can recommend that.
Yeah, either MCLR chair or either the laser.
Yeah, and if both we can do, no problem. We can, MCLR chair is the pelvic floor exercises.
But both will increase the cost, na? Cost will increase the doctor.
But we can charge, see, MCLR chair, we can charge on a very very low cost we can do. It's on our side, no? If it can be like a complimentary thing to the patient. We can make
If
it.
the patient can afford and we are having all the facilities, we can.
Definitely.
One question is from my side.
Doctor.
The unmarried girls are coming 16, 17 years of age with the complaint of the vaginal looseness. So, is it necessary to take the consent from the parents also, because these are living in the live-in relationship and they usually come with the complaint of the vaginal looseness? So, what's your opinion?
I feel any kind of a minor, it's always good to take the consent. So we have to be very sensitive about this. And when you are treating the minors or any unmarried girl with this, see, sometimes sometimes the girls, adolescent girls, they are having unrealistic expectation about the external or internal genitalia. At that age, they may not be really having vaginal looseness. It's the unrealistic expectations from their own self. So it's always good that such people, such age group, adolescents, they need a bit of counseling. They need to understand what is normal. It's sometimes hearing to the peers or reading, these things are sometimes hyped in the social media. So they need to be given realistic expectation of the treatment is very important. When they come for cosmetic procedures, using laser or any kind of surgical cosmetic procedures, be it vaginoplasty or hymenoplasty or clitoral hood reduction or any kind of surgical, they should be given a very realistic expectation out of the treatment. So we, whenever we are doing this, it's important for good counseling. Psychosexual counseling is important. It's important to document what is their expectation and what are you able to deliver to them. And it's important to take pictures. Diagrammatic representation, photographs need to be taken prior to the procedure and after the procedure, because we may end up in some kind of medical legal problems when you're dealing with a 16-year-old minor. And also, I would think a 16-year-old coming with a vaginal looseness or any kind of changes to the external genitalia, they need to be counseled properly, and documentation is very important. We are talking about medical side, it is different. When you're talking about due to childbirth or due to GSM, when you're treating medically, it is different. When it becomes for cosmetic, sometimes it can come under genital mutilation. So they are talking that when you're doing surgeries for alteration of the external internal genitalia just for cosmetic purpose, it can come under female genital mutilation. So we need to be very conscious about it. And counseling, documentation, diagrammatic representation, photography, all of these are very important when you're dealing with that age group and more for a cosmetic purpose.
Thank you. Thank you so much. One last question. Dr. Yusevi has joined from Nigeria. He usually joins my all webinar.
Okay,
His
great.
question, madam, your opinion for the male's urinary incontinence, can we use lasers?
I don't have experience with that, but
in this OPD he is getting a lot of male patients also who are not having the prostate issue. So can we try this?
Yeah, I don't have any experience with that, but sometimes they are saying that this MCLR chair and this electromagnetic chair can help with male sexual dysfunction. Some men with erectile dysfunction and all, the chair is going to strengthen the pelvic floor muscles. There may be a role in sexual dysfunction with the chair, but I don't have any experience with the male urinary incontinence. Yeah.
Yeah. So, Dr. Isevi, still the lot of the researches are going on, still no any such concluded data. In future, if we are having, definitely we will discuss. So,
Yeah.
thank you once again, Dr. Sweta, for joining us and clarifying lot of doubts.
Thank you. Thank you
Thank
so
you.
much, Dr. Ritu, for inviting me. It was a real pleasure, and it was really nice talking to all. Thank you.
Thank you. Thank you. Now, a very important topic which the Kuldeep Singh sir is going to discuss. I think each and everyone is having a lot of doubts related to twin pregnancy sonography. So, without wasting time, I am handing over the dais to Kuldeep sir. Later on, we can discuss the questions, whatever we receive online. Warm welcome to you, sir.
Thank you. Thank you, Dr. Ritu. I hope I'm audible over there and you're
Yes,
able to
yes.
see my screen.
Screen is yet not visible. Yes, now it's visible, sir. Yeah,
Visible? Yeah.
yeah.
Let me just do a slideshow and see whether it's.
Friend, sir is a gem of the person. Whatever the difficulties you are having, sir is always ready to help. Sir, a big salute to you.
Thank you. Thank you so much. Thank you so much, Dr. Ritu. And it's impossible to say a no to you. You're always so kind, and it's always a great platform where we can all discuss things. I hope my screen is on now and you're able to
Yes,
see.
yes, yes,
And
yes,
once
yes,
I
sir.
change the slides, do let me know. Are the slides changing?
Yes, changing.
Perfect. So I'm going to be talking on multifetal pregnancy, more on twin pregnancies, and that's this again topic has been chosen by Dr. Ritu, and fantastic way to really educate everyone. And to be very honest, you rightly said in the beginning that it's always once we're spreading knowledge, we are gaining ourselves. There's so many points every time whenever I take a talk, it's always good to know a few more things. That's the Sono School number. Plenty of you are a part of it. That's an academic platform where we keep on taking these sessions on ultrasound and OBS, gynae, and infertility. And we go by the phenomenon of we question, you answer, and learn. I'm just going to reduce the size of the photographs here so that then we can easily and comfortably look in for. Well, multifetal pregnancies, I'm going to be sounding very basic. We're not going to go in for laser therapy and this on the twins. There's lots of work going on, but I'm going to be talking about just basics on the ultrasound so that you all understand what all needs to be done right from the moment you realize that a person is pregnant and they're carrying twins. They account for 1% of all pregnancies, but
Yeah.
it's seen in much higher numbers in population when we're looking at IVF. I hope I'm audible and you're able to see the screen.
Yes, sir.
Yeah, perfect. So here we're looking at that's the bladder. We're doing an IVF, we're doing anything, and that's what I always say. Please and please always do a transabdominal scan. The first scan always has to be a transabdominal, and then you can keep following it up with transvaginal. Let it be gynae, infertility, or early pregnancy. So here we're looking at 3 gestational sacs. And each of these 3 gestational sac has its own embryo, own yolk sac, so we're comfortable about it. We're looking at a gestational sac with a yolk sac and an embryo, another gestational sac with a yolk sac and an embryo, and we're looking at over here. 3 of them, trichorionic, triamniotic, triplet pregnancy. Multiple, that was a pentaplet. Again, nowadays, in fact, we've stopped doing so many embryo transfers. This was quite a few years ago. Now we rarely see, in fact, they're transferring only 1 or maximum 2, or in some places, maximum 3 embryos. When we're looking at multifetal pregnancies, the role of ultrasound is quite crucial. We need to be monitoring, we need to be planning, and the number of fetuses and their chorionicity and amnionicity has to be determined. Why do we need to be doing it? Because that's how much are they going to be in terms of complications, how do we need to follow up is required. Looking at the number of placental sites where the umbilical cord is inserting is important because we need to be looking at marginal or filamentous insertions. You can have dizygotic twins, that's 70%, monozygotic twins, 30%. Dizygotic are fraternal twins. This feature alone, because we're looking at two ova and two sperms, both of them are getting fertilized separately. So they usually result in dichorionic, diamniotic twin pregnancies. Well, from dizygotic to monozygotic, we can't say monozygotic is always going to be monochorionic, because 20% of monozygotic pregnancies will also be dichorionic, diamniotic. So 80% of all twin pregnancies are going to be twins. Monozygotic, identical twins, it's a fertilization of a single ovum separating into two. Unlike dizygotic, they do not have maternal age, family history, or ethnic predisposition. The time at which they are separating is going to reside on the chorionicity and the amnionicity. See over here, we're looking at dizygotic twins, two separate ova, we're comfortable. Monozygotic twins, single ova, again has been fertilized. You're looking at the morula splitting over there. So the moment the morula is splitting, we're going to be looking at a dichorionic diamniotic. When there is a split at the hatching stage, you're going to be looking at monochorionic diamniotic. And when you're looking at the blastocyst splitting, is when you're going to be looking at momo twins or monochorionic monoamniotic. So you can again see with the green arrows when they are going to be at which stage. The morula, we're looking at hatching stage, and the blastocyst. You're looking at 0 to 3 days, it's going to be dichorionic diamniotic. When you're looking at 4 to 8 days, monochorionic diamniotic, 9 to 12 days, momo twins, and when it's 13 days or more, they're going to result in conjoint twins. Again, looking at dichorionic diamniotic, that's when we're looking at two chorions, two amnions. When we're looking at a fused placenta, again, we need to be differentiating all these things. Or when we're looking at a single placenta, two amnions, or we're looking at a single placenta, one chorion, one amnion. So the way I tell my patients is the kitchens and the rooms are separate. The kitchen is one, there are two rooms, or it's a single kitchen and a single room. What all do we need to be looking at? We need to be dating the pregnancy. We need to determine the chorionicity and the amnionicity. We need to label them, very important. The timing, frequency, and what all do you need to see for the ultrasound. We need to be screening them for aneuploidy. We need to do a diagnosis, screening for structural abnormalities, screening for preterm birth, and the diagnosis and management of discordant twin pregnancies. Well, dating when it has to be done. It should ideally be dated when the crown rump length is between 45 to 84. That's at the time of the NT scan. Again, the dating in a singleton is usually done at 7 to 8 weeks. If we have an IVF over there, there is no problem. We know exact dating of the pregnancy should not be a problem. When we're looking at a 4 days blastocyst or a 5-day blastocyst transfer, or when we're looking at a spontaneous conception and we're doing an ultrasound at this stage, the larger of the two crown rump lengths is supposed to be used for dating the pregnancy. Don't choose the smaller one, use the larger one. It's better to be safe rather than sorry. So let's have a bonus. Let's have both the babies to be on the plus side rather than presuming that we're looking at one normal and one bigger. Let's presume we have one normal and the other is smaller so that we take extra care. We're looking at two gestational sacs. In each of the gestational sac, I'm looking at an embryo and a yolk sac. I'm looking at two yolk sacs in one gestational sac. I'm looking at a single gestational sac and I'm looking at 2 embryos and 2 yolk sacs, both in the same one. 2 yolk sacs, 2 embryos far apart, 2 amnions seen over there. Single gestational sac, cardiac activity, yolk sac seen over there. And we're looking at another yolk sac. So if you see on this, it's a dichorionic diamniotic. If I'm looking at a membrane there, I'm looking at a monochorionic diamniotic. And if I'm looking at 2 yolk sacs, I'm still sure that they're going to result in 2 amnions. So this is also again a monochorionic diamniotic, not a monochorionic monoamniotic. I repeat again, this means 2 yolk sacs means it is a diamniotic one. There you're looking at. But again, we know biology is never 100%. And if you see in this, I'm clearly looking at 2 yolk sacs. No doubts about that. And I went on looking for a membrane in between, but it is a monoamniotic, in spite of the fact that I'm looking at 2 yolk sacs. So again, there could always be variations. You need to be always open for such things. Clearly 2 yolk sacs seen, but the amnion is 1. In terms of complications, all 12 pregnancies are going to have higher fetal and neonatal mortality, with overall rates being 3 to 6 times higher for mortality, 7 times for neonatal mortality. So be watchful. And this is more because of higher incidence of premature labor, and we're looking at the sequelae thereof. The risk of complication again depends on chorionicity. Prognosis worse for mono. Di 10%, mono di 20%, and momo twins more than 50%. We're looking at trouble. So how to determine chorionicity? Between 6 to 10 weeks, count the number of sacs, evaluate the thickness of the dividing membrane. If you're looking at thin one, as seen in monochorionic, count the number of yolk sacs if you're not sure about it. The yolk sac is equal to the number of amniotic sacs. Between 11 to 14, looking for the lambda sign. That's basically placental tissue getting inside a thick membrane in the initial portion. Chorionicity, best at 13.5 weeks. That's basically during your NT scan. And if you're looking at a monochorionic diamniotic, you're going to look at a T sign, dichorionic diamniotic lambda sign. If I'm looking at 2 separate placentas, right wall, left wall, anterior, posterior, there is no problem. It's just when it's a fused placenta or the placentas are closed, that's when we need to be looking in for. Looking at a lambda sign, a thick membrane. I'm looking at 2 amnions over there. So this is finally going to lead to, this is in one wall, but it's a dichorionic diamniotic. Again, the chorion is extending into the membrane. So that's a twin peak sign or a lambda sign. The intertwin membrane is thick. Separate placental masses, we know we are comfortable with. Dichorionic diamniotic, we're looking at each twin having its own chorionic and amniotic sac. 2 gestational sac with a thin echogenic chorion, looking at a thick intertwin membrane more than 2 millimeters, lambda sign. And obviously, we're looking at a yolk sac each in each gestational sac. If there's no placental fusion, we're comfortable about it. In terms of complications, they have the lowest rate of complications. And in terms of, there's always an increased risk of FGR. Placenta-related problems, velamentous, marginal, placenta previa, we all need to be watchful for. Looking at a lambda sign. That's the lambda. the lambda seen over there. The sooner you see it, the better it is. Try and seeing it in the second trimester and the third trimester can be very difficult. So always clear-cut notes have to be mentioned. Whether you're doing a scan or somebody else is doing it, things should be very clear. The lambda sign. The moment it's at 90 degrees with nothing going inside in a thin membrane, that's a T sign. Monochorionic diamniotic. One gestational sac, two yolk sacs. You could be looking at a T sign, that's a thin intertwin membrane, and a single placental mass seen over there. We're looking at two babies, but we're looking at something which is coming at 90 degrees. No lambda sign, that's a T sign. Again, a subtype of monozygotic, single chorionic sac, two amniotic and two yolk sacs. So the yolk sac is the count of the amnions. You can see a single gestational sac with two separate yolk sacs, single placenta seen. A thin intertwin membrane. That's how it differentiates between a monoamniotic one. You're looking at a thin intertwin membrane. That's to tell that there are two of them. The membrane is going to be very thin, less than 2 millimeters, and you're looking at a T sign. In the second and third trimester, again a single placental mass, and the membrane is quite thin. The complications, again because of placental vascular anastomosis, twin-twin transfusion, twin embolization, and trap sequence, twin reversed arterial perfusion. They're much more for Momo, but it can happen in these also. There could be a demise of one twin, problems of placental insertion, velamentous cord, marginal cord, we need to be watchful for. Here we're looking at two gestational sacs, but one of them is showing two babies. Monoamniotic, no membrane, one yolk sac or a divided yolk sac, and you can look in for entangled umbilical cords. Again, subtype of monozygotic, single chorionic, single amniotic, single yolk sac, but two babies over there. The same way, no intertwin membrane, we've explained that to you. Specific, you could be looking at cord entanglement. That makes it sure that there's only one amnion. They carry the highest level of complications. So the moment they're monochorionic, monoamniotic, you need to be watchful. Again, related to abnormal placental vascular anastomosis, twin-twin transfusion, embolization, and trap, which is more common in this rather than the other one. Demise, again, we know the moment in this sort of a condition where we have a single amnion, or as a matter of monochorionic, we need to be very watchful because very soon the other twin is also going to have problems. Related to the placental insertion, velamentous and marginal, umbilical cord related complications like knots and thrombosis happen in this much more. Now coming on to labeling, you need to be right from the beginning label it. You need to be clear cut as to where exactly is the placenta, where is the fetus, so that next time anyone else is doing it or for you also, it should be very, very clear. So the labeling has to be reliable and consistent and has to be documented clearly in the patient's notes. How do we really monitor? Monitoring of twin pregnancy, especially uncomplicated dichorionic twin pregnancy. We need to be doing a first trimester scan. When we say first trimester means the NT scan, a detailed second trimester scan, the anomaly scan, and scans every 4 weeks in uncomplicated. Moment there are complications, you can be doing them much more frequently. At this stage, you're supposed to be doing dating, labeling, chorionicity, and a genetic scan. Anomaly scan, a detailed anatomy, biometry, looking for the amniotic fluid volume and the cervical length. After that, every 4 weeks, you're supposed to be assessing growth, amniotic fluid volume, and the fetal Doppler. Now, for monochorionic, what you really need to do, that to uncomplicated ones. Do a first trimester scan. After that, every 2 weeks, we need to be scanning after 16 weeks so that we can realize when we're looking for twin transfusion or anemia polycythemia sequence. Or when we're looking at monochorionic twins, which are complicated, much more frequently, there is no harm. What all do we need to see? 11 to 14, same. Then after that, from 16 weeks, every 2 weeks, we need to be looking at the growth, the deepest vertical pocket, and we need to be looking at the umbilical artery. Anomaly scan onwards, we need to be doing fetal structure, biometry, deepest vertical pocket, umbilical artery PI, middle cerebral artery peak systolic velocity to looking for any anemia and cervical length. And every 2 weeks, biometry, amniotic fluid, and the Doppler specifically for umbilical artery PI and the middle cerebral artery peak systolic velocity. In terms of screening, when we're looking for genetic screening, especially trisomy 21, we can be looking at the nuchal translucency. We can do it depending on the lab has the normal values when we're doing a combined testing where we're looking at beta HCG and PAPA. Otherwise, normally everybody has started preferring maternal age and NT, but there are plenty of labs which have normals for this, so we can always do a combined testing. Now, what do we really need to be looking at in the translucency? If you're looking at monochorionic, we know the genetic structure is the same, so we need to be averaging out. So we need to add up the NT measurements and divide it by 2. And so that we're going to be giving them the risk analysis same for both of them. For a dichorionic, it has to be done separately, and each fetus is going to get a separate risk assessment. If you're looking at a vanished twin, there is a measurable fetal pole. Ideally, just do the NT alone with the maternal age. Do not go in for combined testing. And in terms of NIPT, again depends on how much is the lab comfortable and what all is the information we're going to be getting it. Now, there could always be a discordance in the NT measurement or the crown rump length. What are the implications? If you're looking at a twin pregnancy with a crown rump length discordance of more than 10% or an NT discordance of more than 20%, please do a detailed ultrasound assessment. Not that you're not going to do otherwise, but you need to have your antennas up over there and you need to be testing them for karyotype abnormalities. The risk of fetal abnormalities, 25% when there's a crown rump length discordance of more than 10%. Otherwise, it's 4% when the discordance is less than 10%. NT more than 20% has a high sensitivity and specificity for twin transfusion. And if you're looking at a discordance as early as 7 to 9 or 10 weeks, it's a predictor that things could go bad with one of them and there could be a fetal demise. Looking in for structural abnormalities from the top of the head till the feet, please do a detailed analysis. A routine second trimester scan, anomaly scan has to be done, and you need to be asking for a fetal echo. I normally say in twins always, but the book says in monochorionic twins, it's definitely indicated for. The risk of anomaly greater in twins than in singleton. In dizygotic twins, it's almost same, 2 to 3 times higher in monozygotic. 1 in 25 in dichorionic, 1 in 15 in diamniotic, 1 in 6 in monoamniotic, where you could be looking at a congenital anomaly. Looking for preterm birth, the gold standard is a cervical length measurement, and if you're looking in for any herniation of the amnion, any internal os widening, or a cervical length of 25 millimeters, you need to be watchful. How effective is just giving a prophylactic cerclage? I'll not go into all those discussions because me not in that field, but there are plenty. The moment there's a twin, they go in for a cerclage. In terms of looking for FGR, that's one of the most important things. And when we're looking at an FGR, is a weight below the 10th percentile or an inter-twin discordance of more than 25%. And how do we calculate that? I'll let you know. The discordance more than 20% is acceptable to distinguish pregnancies at increased risk of adverse outcome. How do you calculate the discordance? The weight of the larger twin minus the weight of the smaller twin, meaning the difference divided by the birth weight of larger twin multiplied by 100, and that will give you the discordance. And if it's more than 20%, you need to be extremely watchful. In terms of monochorionic ones, you need to be classifying for their FGR depending on how the umbilical artery is behaving. We're going to be looking for middle cerebral, we're going to be looking for ductus venosus depending on early, late, but that's what gives us the warning signal. If you're looking at forward flow in and diastole, but which is reducing, we know we need to be watchful. Survival in this is more than 90%. There you're looking at forward flow, but it's reduced. The moment you're looking at absent or reversed, we know there's a high risk of IUD. You need to be following them up very carefully. Whether it's going to be one of them which is going to give trouble, and then gradually the other one is also going to be, you need to be watching out for them very carefully. Absent or reversed and diastolic flow. If you're looking at a cyclical or an intermittent pattern of absent or reversal, that is one which is really going to be extremely troublesome, where it's going to be up to 20% associated risk of neurological morbidity in the surviving twin. So be very watchful for these. How do you need to follow them up? In dichorionic, if you're looking at for FGR, every 2 weeks, again depending on the Doppler severity. In monochorionic, you need to be following them at least weekly or might be every 72 hours so that we don't miss out on it. Close follow-up with the proper Doppler is extremely helpful. Last slide to summarize. Ultrasound assessment of fetal biometry, fetal anatomy, Doppler velocimetry, amniotic fluid volume is used to identify and monitor twin pregnancies. As in singleton, if you're looking at problems in fetal growth, again in twins, you're going to be looking at biometry. In this, you're going to be comparing both of them, looking for the Doppler velocimetries in each of them, and we have standards as in uncomplicated pregnancies. So be watchful right from day one when you're scanning for twins. Even if it's a 7 to 8 pregnancy, a 7 to 8 weeks pregnancy, start looking at for the number of, don't straight away label it. Write clearly in your report how many gestational sacs, how many embryos in each gestational sac, how many yolk sacs in each of them, so that we're very clear right from the beginning. Then an NT scan, depending on whether it's monochorionic, dichorionic, after 16 weeks or after an anomaly scan, we follow them every 2 weeks in monochorionic or every 4 weeks in dichorionic diamniotic twin pregnancies. Again, we need to be watchful for doing the fetal biometry so that we don't make a mistake. There is nothing like a precious pregnancy. I always say that to all my delegates. Every pregnancy is precious. Ask any mother and who's not going to say that each of my babies is precious. So let's work hard. Sometimes it's really dilemma whether we should be saving the smaller one as well and hazarding the bigger one, or should we let go the smaller one so that we're able to make the bigger one comfortable. Thank you. Thank you so much.
Thank you, sir. Thank you so much. Sir, such a nice presentation. You have covered each and everything. Sir, till now I haven't received any question. Only I am able to see lot of appraisals. Everybody saying the lecture is very good. Videos are very nice. So,
That's what I
doctor,
say. That's what I say always, that if there are no questions, means either I've confused everyone a lot or I've made it too simple. But I don't think so. I've made it too simple. I've made it
no,
too
no, sir,
complicated.
this is quite good, very good, because program has been attended by a lot of PG students also. So it
I'm so
clears
glad.
all our basics. No, sir, that's very, very nice.
I'm so glad.
Sir,
I'm
one
so glad.
comment I have received from Dr. Mustafa. He has joined from Dhaka. Very nice lecture. Dr. Ritu, please invite such kind of good doctors. Acha, acha. Very nice. And besides that, here also in the chat box, I am also able to see Renu Madam has also written that very nice lecture. So thank you, sir. Thank you, Dr. Sweta. Sir, no questions, only the appraisals we are getting.
No
So thank
problems.
you.
No
Yeah,
problems.
yeah.
Thank you. Thank you so
Thank
much.
you. Thank
Always a
you.
pleasure to be with you, Ritu. Thank you so
Thank you, sir. Thank you so much. So, friends, with this, we will wind up for today. I know this is the OPD time. Everybody is now rushing for the OPD. So, thank you to those all of you who have joined. And next week, we are coming with the international faculty. I will post the flyer within 2-3 days with the same time at 3:30 p.m. Thank you, Shield Pharma. Thank you, Sahiti, for constantly providing the platform from last 3 years. Now, taking your leave. Bye-bye.
Thank you. Thanks, Ritu. Bye-bye. Bye.
Yeah. Dr. Khalida, you have joined late. We are closing the meeting.